Yes, I will go ahead and share the
person?
slides. Let me go ahead and
Just
get
want to make
those.
sure you're the person doing it. We're not
Yep.
assuming
Make sure
someone else
this.
is doing it. Thank you. Thanks.
Thanks. Okay, I'll send it over to you, Siobhan.
All right. Oh, I apologize. Just a moment. Sorry. Okay, now I've got it all loaded. Thank you very much for joining us today. So I will be starting off the presentation before I hand it over to Abraham and Wendy. We broke this out into 3 parts, kind of talking about the epidemiology side, the environmental health side, and then the communicable disease nursing side. So that's how we're going to go through this presentation today. And I will go ahead and start off with the disease history and etiology. So again, my name is Siobhan Burns. I'm the communicable disease epidemiologist for Washington County. And I'm going to start talking a little bit about the history, about Legionellosis, and then also talk about the disease etiology and what causes the disease. So back in 1968, visitors and staff to the Oakland County Health Department in Pontiac, Michigan were stricken by a fever of unknown origin. They were taken by an acute febrile illness characterized by a fever, headache, myalgia, and malaise, and it affected 96 of the 100 employees at the office. An additional 48 or more visitors also reported being sick with illness. The incubation period was relatively short, and it was just about 36 hours, with the disease seeming to be self-limited to 2 to 5 days of illness with no known transmission to secondary cases. Due to the rapid onset and strong evidence that all the cases were linked to a single location, this suggested that it was an environmental exposure. It was later determined to be related to a defective AC system or air conditioning system, but the causative agent was not found at that time. 8 years later, during the summer of 1976, the American Legion held a convention in Philadelphia, Pennsylvania, celebrating the bicentennial year, which marked the 200th anniversary of the signing of the Declaration of Independence. The event was held at the historic Bellevue Stratford Hotel, which is in the heart of the city. Over 2,000 members of the Pennsylvania chapter of the American Legion gathered at the convention with their spouses for 4 days, during which there was a temperature inversion. This created a local heat wave, which kicked on the air conditioning system at the hotel. Here you can see a historic photo of the hotel, which has cooling towers up on the top of the roof. And that was something that was really common in like large buildings and especially in early air conditioning systems. Within 3 weeks, 182 cases were reported with serious presentations of atypical pneumonia, with most of them being attendees to the conference. What was strange is that a case was reported from a bus driver whose route was near the hotel, and then other people had simply walked around the hotel but had never actually entered the hotel itself. Another case was a reported case from one of the air conditioning technicians that worked at the hotel, and this was all really puzzling to the health officials. The CDC looked at every possible route of exposure, swabbing the resident parakeets for psittacosis, measuring the cadmium levels in the pitchers used to serve Bloody Marys, and they also ruled out an outbreak of swine flu, which had been recently diagnosed at Fort Dix just a few months before and is only about an hour's drive away. 29 deaths were attributed to this outbreak, and researchers were desperate to try and determine the cause. It was not until Christmas that year that Dr. Joseph Dade of the CDC reported clusters of rod-shaped bacteria in the livers of little guinea pigs that had been injected with the lung tissue from sick patients. With the help of his colleague Charles Shepard, they were able to isolate the new bacterium. In January 1977, the CDC was able to identify the new bacterium from environmental samples taken from the cooling towers, and they found the bacteria were breeding in the stagnant water. This sudden temperature inversion caused a condensation reaction in the cooling towers created by a rapid cooling of the hot ambient air and sending a deadly mist into the ventilation system. The cooling towers are very large and is basically a passive form of air conditioning. They also generate a curtain of cool air that runs down the edge of the roof because it's not as centralized as a modern air conditioning system is. And this airflow created this curtain of air that went down over the side of the hotel and descended along the outside of the building, dispersing the bacteria very widely into the surrounding area. Interestingly, the few outlier cases would actually portend something unusual about the spread of this disease. The hotel was permanently closed in November 1976, with just 4 months after the convention, due to the gaining national notoriety associated with the outbreak and the stigma attached to the building. The building was later sold and renovated and restored, and it's actually still in operation to this day. So what do we know now? Science has advanced significantly since the bacteria was first identified in 1977. We know that Legionella represents a large group of over 50 bacterial species that are common in aquatic environments, and certain species are associated with soil and compost, especially with potting mixes, because the bags hold the moisture in them, and then that ongoing decomposition creates a warm, nutrient-rich environment for the bacteria. The environmental strains are not transmissible person to person, and most people exposed to these organisms through work or recreation like construction or gardening will not become ill because the bacterial load is just too low to cause infection. In the built environment, including our homes and industrial buildings, the bacteria can flourish in water systems and reach concentrations high enough to cause infection if the contaminated water droplets are aerosolized and inhaled. These aerosolized particles can be transmitted up to 15 kilometers or almost 10 miles from the source. The case is identified in the American Legion outbreak, including the bus driver and the pedestrians that were near the Bellevue Stratford Hotel during the Legionnaires' convention, provided some clues about how far this deadly aerosol could be distributed and over a very significant distance. This exposure circumference could actually potentially even spread further than 10 miles, depending on wind patterns, localized weather phenomena, or even airflow patterns created by buildings or other large prominences. Generally, Legionella is not spread person to person, but there have been very few cases reported of secondary cases among close contacts or caregivers. Extrapulmonary Legionellosis is very rare as well, and it's typically associated with endocarditis or wound infections in hospitals where non-sterile water was used either during the procedure or later for wound care. Legionellosis is a bacterial illness, and although any Legionella species can cause the disease, up to 90% of the identified cases are caused by a specific species, which is called Legionella pneumophila. The species name Pneumophila roughly translates from Greek to lung lover, and once inhaled, the bacteria will invade human macrophages. This is unusual because the macrophages are essentially our germ-eating cells, and in humans, Legionella pneumophila, acts as an intracellular parasite. It's likely developed this as a mechanism of infection. This mechanism of infection is simply a byproduct of evolutionary adaptation. Amoeba are the natural host for Legionella and are found in freshwater lakes and rivers, which are generally very nutrient-poor environments. Legionella will bind to extracellular receptors on the amoeba, hoping to get eaten by the amoeba. And once the bacteria has been phagocytized, they wall themselves off in the vesicle and replicate in the host until conditions improve. Eventually, they'll be released back into the environment once conditions are more favorable. In the photo on the left, you can see the bacteria dividing within the vesicle of the amoeba, and it's pointed out by those black arrows. That's actually where the long gram-negative rods are dividing. In humans, when the bacteria inhale, they reach deep into the lungs where the bacteria will bind to the alveolar macrophages and become engulfed by the phagosomal vacuole. The bacteria prevents its destruction by preventing the macrophage from binding the lysosome, which will acidify the vacuole and destroy the bacteria. By inhibiting this crucial step, it essentially creates a little protective bubble in which it can rapidly multiply and utilize the cellular material for its own replication. The bacteria will replicate so much so that it'll eventually cause the macrophage to burst, releasing the bacteria and the bacterial enzymes. This will in turn trigger the recruitment of neutrophils, monocytes, and fibrin as the body responds to the infection, creating a destructive inflammatory response in the alveoli, which manifests as severe pneumonia. So Legionella is a gram-negative rod, which means that they have kind of a slimy lipopolysaccharide coating, as well as a thick peptidoglycan bilayer in their outer membrane. This makes it very resistant to many disinfectants. The bacteria are motile due to the presence of both flagella and pili, and they also exhibit a form of sliding motility. They can secrete a surfactant, which reduces the water tension, which allows them to slide like a snail through our mucosal secretions and move deeper into the lungs. Legionella are also relatively resistant to chlorine and can tolerate the temperatures found in most household hot water heaters and can form biolayers and biofilms inside the plumbing. Because they are slimy, they can create a protective layer along the inside of pipes where they can commingle with other bacteria to form a microbial community, and this is what we refer to as a biofilm. So then what is Legionellosis? Legionellosis is actually an umbrella term that includes all presentations of the disease, which includes Legionnaire's disease and the less severe Pontiac fever, but also any extrapulmonary infections, typically associated again with wounds, surgical procedures, or contaminated tap water and wound care. The mode of transmission for both Legionnaire's disease and Pontiac fever is droplet inhalation from a contaminated water source. Legionnaire's disease is the more dangerous form of the disease, and it's distinguished by the symptom severity, which includes potentially fatal multilobar pneumonia. Legionnaire's has a long incubation period, and it's much longer than Pontiac fever. It should also be treated with antibiotics, whereas Pontiac fever is generally self-resolving within a few days. It's also more likely to result in long-term sequelae, potentially death, and very long convalescent times that can last weeks or months. Pontiac fever is typically much more mild, flu-like, it has a rapid onset within hours to a few days of exposure. The disease is typically self-limiting. Antibiotic treatment is not recommended because for most part, people are able to get over it without any additional treatment or medications. Pontiac fever is likely very underreported since it resembles flu symptoms, and the cases are less likely to seek treatment as well as testing unless there has actually been an identified outbreak. So this brings us to our first polling question. Severe pneumonia is a defining characteristic of A, Legionnaire's disease, or B, Pontiac fever. I'll give you just a few minutes to respond to that. So Legionellosis is actually much more common in the Midwest and the East Coast than here on the West Coast. It is seen especially at very high rates in Illinois and Ohio. There is a much higher incidence in the summer months. That's because we start to see those cases spike up between May and June when our air conditioning units come online, and these cases can persist all the way into September and October. That's why we're presenting on this topic now, and we want you to be aware of the risks as we approach the summer season. Most cases of Legionellosis are associated with healthcare settings, followed by travel. Long-term care facilities remain an important site of exposure because of the vulnerable populations that are served in these settings. I'll now pass it over to Abraham Shadbay to discuss environmental sources and preventing exposure.
Hi there, I'm Abraham, and I'm just going to talk real quick about some sources and ways to mitigate that with regards to Legionella. So any device or plumbing using sterile water, non-sterile water can grow Legionella. Some common routes of exposure include the things that you see here, which is shower heads and faucets and sinks, sink faucets, hot tubs, decorative fountains, water features, hot water tanks and hot water heaters, cooling towers, although these are generally used in industrial settings or older buildings. There's a picture later of a cooling tower. Large complex plumbing systems and what we call dead legs. Dead legs are like where there are dead ends and the water's pooling and not being flushed out regularly. Let's see here. Cooling towers. So they're often confused with refrigerant-based air conditioners. The following general characteristics and features of cooling towers help to distinguish them from AC units. Cooling towers are generally come in a variety of shapes and sizes. Most buildings have some type of cooling system, either cooling towers or AC units. Buildings without a readily visible air cooling system warrant further investigation. Sometimes these things are identified by overhead imagery on buildings because that's where they're usually found. So going on to plumbing prevention. So breaks in the water mains or leaks can introduce sediment and dislodge biofilms and increase the risk of Legionella exposure. This can also happen when there's like construction in the building or the building's plumbing system is being worked on, or when the water flow is turned on or off. You should practice regular flushing of fixtures in unoccupied rooms or areas of the facility that are unused. This will prevent that branch of plumbing from becoming what's called a dead leg, in reducing water stagnation, which encourages sedimentation and the growth of biofilms. We shouldn't forget about other dead-end pipes like eye wash stations that are kind of rarely used probably. They need to be periodically flushed to remove stagnant water. Ice machines also need to be regularly serviced and are prone to getting colonized with mold. There's a nice picture in here with that on the next couple slides. The Water Bureau controls microorganisms by treating the water with chlorine and by maintaining the distribution system to deliver safe and reliable drinking water to your property. Once water enters the home or building, the resident or property owner or building manager, they're responsible for maintaining the water quality in the home or the building plumbing system. Chlorine activity decreases the farther that you get from the treatment plant, increasing the likelihood that Legionnaires can survive and be established in a biofilm in plumbing. You can test your chlorine levels in the facility to ensure each branch in the system is adequately chlorinated. Drinking water levels should be between 0.1 and 0.5 parts per million if you're running spots to test in your facility. Just a side note, drinking water can have up to 4 parts per million water, so this is only 0.1 or 0.5. Testing for Legionella is not recommended because it's naturally found in freshwater environments. Its presence doesn't always mean it will cause infections, and testing may result in false positives. So make sure building managers should focus on mitigation rather than measures to prevent aerosolization of that. Next slide here. So this is some pictures that I've added. Just the one on the left is just overly complicated plumbing. It's kind of a caricature of what you think is kind of bad plumbing. So, but this, you want it to be as simple as you can make it. And obviously this is a problem. This other photo here is a typical item we see in restaurants and even long-term care facilities, because long-term care facilities also have these huge ice machines, and they get dirty inside, and water filtration doesn't remove this. This grows by itself, and it can get pretty gross in there. We've seen some pretty bad ones. Moving on to aerosolization devices. So these nebulizers that you see, humidifiers, CPAP machines, and other respiratory equipment that creates vapors or mist could potentially spread Legionella. Nebulizers, CPAP machines, and mouthpieces, masks should be sterilized according to the manufacturer's instructions. Many can be rinsed in fresh water and boiled, sterilized, or cleaned with a mild detergent and allowed to air dry. For nebulizers, use only sterile, or single-use prescription medication for the units. We would also caution against using the popular tiny essential oil mini humidifiers. If you're using one of these at your desk or home, try to use boiled or distilled water instead. And just some general recommendations that you see there: empty the tank and reservoir daily. It's just really important that these things get cleaned up. All right, moving on. So shower heads and aerators. You should be cleaning the aerator every 6 months or more regularly if you notice a decrease in the water flow or scale accumulating on the faucet or shower head. Most fixtures can be cleaned by removing the aerator or shower head and hose and soaking them overnight in white vinegar to dissolve mineral buildup. The fixtures can be rinsed and reattached for use. Some manufacturers may recommend cleaning with specific agents, so check the manual for preferred descaling agent. See here. A lot of people will descale this by putting a bag of vinegar with a rubber band over this so that the head is immersed in the vinegar. So try to follow manufacturer recommendations for doing that. Okay, so water heaters. The water heater should be set greater than 140. When flushing hot water taps, run the water until it reaches its highest temperature. And regularly flushing is recommended by most manufacturers of water heaters. Follow the manufacturer's instructions or have a professional do the work. Replace the anode rod every 3 to 5 years to prevent corrosion. And also flushing the tanks after doing plumbing work if the water's or after plumbing work, and if you see water that's discolored, and minimally annually. All right. Polling question. How can you reduce the likelihood of Legionella growth in the plumbing? Here's your answers there. See where you go with that. Yeah, so flushing. Oh, not done yet.
Abraham, did you want to read the correct answer?
Yeah, sure.
Okay.
Sorry. Thank you. So the correct answer is flushing the faucets weekly and using bottled water for the CPAP machines. So great. And then a lot of just dispelling some myths. Small home and car air conditioning units they're not a risk for Legionella, and they don't use water to cool those things. It's not spread from person to person, or it's very unlikely. And Legionella does not cause infection from consuming it with food or drink. You've got to really inhale the droplets for you to be infected. And then preventing Legionellosis. Remember how it's spread. So we're thinking about ways to reduce the chances of residents becoming sick with Legionellosis. The easiest way is to consider how the bacteria is spread. And recommended mitigation measures may include flushing of the facility's water systems and installation of point use filters, and flushing water fixtures in patient rooms and staff in public areas. So using filters and such too. Thank you.
All right. Thank you. I'll pass it over to Wendy.
Thank you. Next, we're going to talk about disease control and response, not only by you as a long-term care facility, but also the health department. Because if we ever see even one case in your facility, we want to hear about it and work together to try and figure out where it came from, and try and remedy that situation so it doesn't go infect or affect anyone else in your facility. So prompt response is really going to be the biggest thing. You don't have to be an expert in Legionellosis, but you certainly need to know enough to see the signs, hear that word, and know when to contact us so we can work with you right away. So very, very important. So how does this all fit with your long-term care facility? Why should you care about Legionellosis? There's lots of diseases out there. I know we're dealing with COVID and the flu and maybe some gastrointestinal things. But Legionellosis, while it doesn't happen that often, when it does, it's a big deal in your facility. So we want to be always thinking about Legionellosis in your, or Legionella, Legionellosis, Legionnaires, Pontiac fever, any of those buzzwords are things that need to get your attention so we can jump on it right away. So who's at risk? Quite a few people, especially in a long-term care facility, even your staff. So Legionella is just out there. It is in the environment. We all could be exposed to Legionella in our lifetime, never get sick. Because we're healthy people, maybe we're younger, we don't have any comorbidities or health issues that we're dealing with. So most people will be exposed at some point and never get ill. However, those in long-term care facilities really are higher risk because of just the nature of why they're there in the first place. Anyone over 50 or 50 and up, and of course, those 85 and older are at higher risk. As people live longer and longer, there's more risk that will happen. Current or former smokers, anyone with chronic lung disease such as COPD. I know that's something, if people are lifelong smokers, end up with COPD or emphysema. People with swallowing disorders because of risk for aspiration, people with weakened immune systems or the immunosuppressed, those who are going through chemotherapy, those who might be on immunosuppressive medications such as Humira, Remicade, other things for rheumatoid arthritis, or there's other gastrointestinal illnesses that people are on immunosuppressive drugs, which lowers their immune system, making them more susceptible. And of course, others with people with underlying illnesses, diabetes, kidney, liver failure, other issues that they're dealing with, their body is compromised. While this probably applies to most of your residents, it also could apply to some of your staff as well. So it is important to pay attention to Legionella, at least periodically familiarize yourself and your staff with what it is and when to contact us. So think Legionellosis when we have multiple patients or staff with cough, shortness of breath, fever, muscle aches, and headaches. Now, that could be a lot of respiratory things, but so I think no matter what, whether it's Legionella or it's a flu or it's COVID, these are things that should be getting your attention regardless, and prompt diagnosis is really important. Other possible symptoms of Legionella or Legionnaires is diarrhea, nausea, and confusion. Again, a lot of these symptoms can be applied to different things. Well, it's important to have them see a provider. Definitely get a chest x-ray to confirm if they have pneumonia. But we really need that evaluation and prompt testing right away. So as soon as we know what it is, then we know how to intervene. Diagnosis and treatment. It is a combination of things. There's not just one test that's going to give you a Legionella diagnosis. Most importantly, we're getting that chest x-ray that's going to let us know, is this a pneumonia of some sort or not? That could differentiate between Legionnaires and Pontiac fever, or it could be something else, as we know. But where the actual testing to know whether it's Legionella, that is what's causing their illness, is a culture of their respiratory secretions, or their lung tissue or their pleural fluid. So while they're let's say they're going to the emergency room, or they've been hospitalized, we're hoping that they're getting a test, some sort of respiratory secretion, lung tissue, or pleural tissue testing. There's also a PCR test, which is a test that detects for Legionella DNA. And then also possible to get a urine antigen, which is basically a urine test, which would indicate if there's a Legionella marker that causes an immune response, or a fourfold or greater rise in their titer, which is a blood test for Legionella. Of course, that's done over a period of time, so often that'll take a little bit longer. The best testing combination for getting that Legionella diagnosis is a chest x-ray, a culture, and the urine antigen. So all three really gives us the best picture of what's going on. I know that's not testing you will necessarily do in your facility unless it was something very extreme, or even us at the health department. Normally this would be done at the emergency room, but or in the hospital. So treatment for Legionnaires, as we've learned earlier, there is no antibiotic treatment for Pontiac fever, but there is for Legionnaires. It is a bacteria, so we can give an antibiotic. As we know with viruses, there is no antibiotic for a virus. Whether that's oral or intravenous, the difference between the two is intravenous is a little bit more impactful, especially if someone's very, very ill. It's going to get straight into the bloodstream. If someone is really incapacitated and they aren't able to swallow pills for a variety of reasons, whether they're really ill from Legionella or they just can't swallow pills, the IV route will be what will occur. Of course, there's also oral antibiotics, and they're actually quite common antibiotics for treatment of Legionellosis. So they're not anything really unusual. It's usually the fluoroquinolones, such as levofloxacin and moxifloxacin, or the macrolides, such as azithromycin. So that will be determined by the provider how they want to treat them. But it's not like an unusual antibiotic or something really expensive or hard to obtain. It's very common treatment. So hopefully we have prompt treatment for these folks so they'll come back and survive. Most will be treated as long as it's done in a timely manner. And then there's no preventative treatment for any non-ill residents or staff. So let's say we have a case of Legionella in your facility. We don't need to go around treating everybody in the facility prophylactically unless they start coming down with symptoms and we've determined that there's a Legionella problem in your facility. So there won't be this mass treatment unless it was something extremely unusual or widespread. A provider may decide they want to treat someone with that. That would probably be up to the individual's provider if they like to do that. So complications with Legionella, looking at Legionnaire's disease in particular, because Pontiac is much more mild. But those with Legionnaire's disease, most will recover, but there can be complications such as hospitalization, lung failure, and death. And if you can read here too, about 1 out of every 10 people who get sick with Legionnaire's will die due to complications from their illness. For those who get Legionnaire's disease during a stay in a healthcare facility, about 1 of every 4 will die. So this can be very tragic. And if it's something that can potentially be, that's why we want to remedy it, hopefully prevent it in the first place, but also remedy it if we find out there's a problem so that it doesn't infect the wrong person, the person that is going to eventually pass away from it. We'd like not to be an environmental cause of, they're supposed to be at your long-term care facility, hopefully being cared for and deal with their other issues that's going on. We certainly don't want to have your facility be the cause of their passing. So very, very serious, can be very tragic. So what do you do if you have a case or you don't even know, is it a confirmed case? Is it a suspect case? You don't necessarily have to figure that out. You're not the provider diagnosing this person. But if you hear inklings from a provider or from a family member of someone that was just admitted to a hospital, if they mention Legionellosis, Legionnaire's, Pontiac fever, or you notice that there's X-ray confirmed pneumonia in 3 or more residents, whether it might be Legionnaire's, it may be something completely different. If you notice any of those words being mentioned, or you have a bunch of people with pneumonia, 3 or more, that's a reason to give us a call. So we want to hear about it, even if you're not really sure. We've gotten countless calls, not necessarily about Legionellosis, but even from daycare providers, schools, other facilities calling saying, I think I'm hearing this is what's going on. And even if it's a false alarm, we'd rather hear about it now in case it turns into a real situation. We can always dig into it and go, no, it's not. They thought it was, it's not. So, but if we hear about it right away, we can jump on it quickly. What we fear is we hear about it a week later, and meanwhile, you've gotten more people coming down with symptoms, and we're having to play catch up to try and figure out what's going on. And of course, this should go out without saying, and you're all very cooperative with our health department. Just really cooperate with us, with the health department between both the facility and us. We're here to help you. Our goal is to make this go away, right? You want it to go away, so do we. We all want to go home at the end of the night feeling good that we've taken care of this outbreak or this situation. So we really try and work with you. We kind of, a lot of people will be involved. We'll have our community health, our public health nurses involved. You'll be dealing with at least one of our public health nurses for some interviews, possibly more, possibly me, maybe our health officer. Environmental health as well will come in, and then there could be a variety of other people. But our goal is not to make your life more difficult. It really is to help get this to go away. That's what we want to do. And then there's no need to isolate or cohort cases. As we've learned, it is extremely rare for person-to-person transmission of Legionella. If you feel more comfortable having someone, especially if they're very, very contagious, they're coughing and they're still in your facility, you certainly can isolate them. Or if you have multiple cases, you can put them together. But it is not like COVID or the flu and other really contagious person-to-person bugs out there. So hopefully you're familiar with our long-term care facility outbreak guidance. If not, we can certainly get that to you. This is the back page of the long-term care facility outbreak guidance. This is sort of more the first page is a little bit more written and text-based or heavy. This side is a bit more kind of visually, maybe a little bit easier to follow depending on your learning style. And this is where you also, in case you forget when you need to actually contact us, on this particular page, as you can see, where Legionella fits in, because it is a reportable disease. We have to hear about it and we have to follow up here at the health department. Any case or cases or suspected outbreaks of a reportable disease. So that could be anything, right? But that encompasses Legionella or Legionellosis or Legionnaires. Any of those things, please report to us. Even if you just heard about it, someone just said it, please let us know. Also, or the X-ray confirmed pneumonia in 3 or more residents. Our role, in a nutshell, it's a lot more complicated than this, but in a nutshell, our role is we have to follow up because it is a reportable condition. We are notified also whether we hear from you, perhaps we hear you may be calling us about cases. We're also supposed to hear about cases from providers, hospitals, laboratories, and congregate facilities or others affected. We hear about it from a variety of ways. But even if we've already heard about it, don't be shy. Feel free to also report. We'd rather hear about it twice than not at all. We would provide a case interview with the person. If we can't really talk to that person for whatever reason, maybe there's maybe they're too ill, they're in the hospital, maybe they have dementia, they're not a really adequate historian. We may be talking to you to get some more background or a family member if necessary. We'll perform an environmental investigation and testing. And then if the source is discovered, we will work with the facility to prevent the spread to others. So really it's about getting rid of whatever is causing people to be ill. And sometimes we don't figure it out. Unfortunately, it's really sad. If there's an outbreak, so there's some protective actions to take during the initial investigation. I'm going to go through these quickly since I'm running low on time. If we find out in the beginning, very, very beginning, we haven't done our full investigation, but we're trying to figure out where it's coming from and why and what can we do about it. In the meantime, we would suggest any residents not taking a shower, since it creates that water mist that could be inhaled while they're in the shower. Preferably take a bath. But filling the tub really slowly, trying not to make it too steamy in the bathroom, any chance to basically minimize that inhaling of the water vapors. When washing dishes, we want to fill the sink slowly. Again, prevent that misting and spraying. Drinking cold water from the tap. Consider using bottled water for drinking, particularly, and then heating that cold water real hot to kill off any Legionella. Turning off and avoiding decorative fountains or other water features that you might have in your facility, on your grounds. Turning off and avoiding hot tubs or hydrotherapy tubs. Avoiding stagnant water. So if you have any stagnant water, please dump it. Could be after a rainy season. We have a lot of standing water. That goes with also dealing with mosquito-borne diseases as well. This would be a good reason. If we have a Legionella outbreak, we can stop new admissions or close affected areas or buildings. We wouldn't want to introduce anyone new to that. And of course, notifying all staff residents and the residents' families as well that this is going on. So in a nutshell, control and prevention, there is no vaccine to prevent infection. Any prophylaxis, meaning giving antibiotics before anyone is sick, is not effective. That doesn't prevent it. It's only if they've already got the bug in their system, they're already sick. We're going to remedy the source of exposure by eliminating environments hospitable to bacterial growth, and then take ongoing measures to prevent future exposures. So on to my polling question. A facility should contact a health department when a patient is diagnosed with Legionellosis, Legionnaire's disease, or Pontiac fever. There is an outbreak. There is an X-ray confirmed pneumonia in 3 or more residents. They have questions about Legionellosis, or all of the above. Give you a moment. All right. We're all A+ students here. All of the above. You can call us at any time if you have any questions. We're here for that. Great. So next few slides that we will send out these slides to you afterwards are some great hyperlinks if you really want to dive into Legionellosis or Legionella, any of these things. There's a great toolkit, a lot of information helpful through the CDC. So feel free to review these resources. Some of our resources with the county. We have a main page for our Washington County Long-Term Care Facility resources where I believe these presentations are stored. Washington County Long-Term Care and Adult Foster Home Outbreak Guidance, which is a quick reference guide, which we kind of referred to earlier. Infection control for respiratory pathogens in long-term care facilities, and then required reporting for health care associated infections. And here are some more, some great CDC toolkits and other hyperlinks to please explore and share with your staff as needed.
Okay,
So
thank
great.
you. Yeah, I appreciate that. I just wanted to acknowledge Ann Schwint, who's one of our communicable disease nurses, a public health nurse. She helped prepare this presentation, and Ashley Davis as well, who is one of our registered environmental health specialists. She provided a lot of information and helped Abraham and myself develop the section for the environmental health area of interest. And thank you, Wendy and Abraham, for helping as well. So thank you very much. And I guess we can open it up for any questions.
And thank you, Siobhan, by the way.
Yeah, thank you.
Feel free, either you can come off of mute or put your question in the chat if you have one.
And while we wait, also for the long-term care, just a reminder about our main phone number here, the 503-846-3594. It is answered Monday through Friday, 8 to 5, or we promptly listen to the voicemails that come in during those hours. If there is an after hours line, but you have to call that number first, then the voicemail message will prompt you to call an after hours line. And then there's our fax number. And then below is our main email, which is if you like to connect via email, this is our main email to use for any disease, whether it's STI, HIV, communicable disease, or tuberculosis. We have one main email, and our administrative staff gets it to the right team.
Thanks,
I'll be
Wendy.
quiet. Yeah.
Yeah, thank you.
Okay. We can send it over to Tyler, who's going to do a little bit of a clarification on some of the respiratory guidance.
Sure, thank you, Bridget, and thank you to the presenters. I found that interesting myself, especially some of that history, how it was discovered. Yeah, so I'm just jumping on today to touch a little bit on the updated CDC respiratory guidance for the general population. So this was updated, I believe it was early March, so a bit ago now, updated respiratory guidance for the general public. So that encompasses COVID, flu, and RSV. So among kind of within that guidance, one of the kind of big changes that I know jumped out to a lot of folks was updated recommendations for when folks should isolate or stay home. So moving from that specifically for COVID, from that time-based isolation period to a more symptom-based approach to how to determine when to stay home. So just jumping on here today to provide some clarification that guidance, that isolation guidance does not apply to healthcare facilities, including long-term care facilities. So for any of your facilities, the guidance would still be for that kind of time-based isolation period for COVID, which is the 10 days if no testing is performed, or 7 days with a negative test, day 5 through 7. I don't think there's been a ton of confusion around that. I think folks have been still having, staff stay home appropriately and residents isolate appropriately. But just wanted to provide that clarification. And if there are any questions on that, we're here to provide to answer any questions. All right, thank you, everyone.
Thank you. Appreciate it. Okay, so for our next meeting, the plan is to hold that in August or late August, sometime around as we're getting ready for, unfortunately, the next respiratory season. We are always amenable to any feedback that you all would like to give us in terms of what you would like to hear about in any of these meetings and future meetings that we have. We want to make sure that we're meeting your needs and being responsive to our community. So please do reach out to us for that. As Wendy said, I will send out the slides, and then eventually this recording will be housed on our website, the resource page for long-term care facilities on our website, and I will stop recording.